PHERGain study is an extraordinary study in different ways. The most important is a trial that we have provided for the first time that we can treat safely patients with locally or early breast cancer HER2 positive with exclusive anti-HER2 therapy, and for a vast majority of them without chemotherapy. The second extraordinary thing about the study is that we have tumor samples as well as plasma samples from all those patients. All are being followed for years and years. So the idea to combine this data was extraordinary, not just for the PHERGain, but also for REVEAL GENOMICS, in order to try to validate how helpful could be this platform in the future, both for the trial design as well as in clinical practice, not just to escalate, but also to de-escalate treatment. We are doing personalized treatment for years. HER2 is a very strong predictor of sensitivity to anti-HER2 therapies, and it's because of that that we have been able to improve the survivals in this phenotype over the last years. What's the next step? The next step is trying to de-escalate treatment in as many patients as possible. We know that with the anti-HER2 therapy itself, we are able probably to cure about 40–50% of those patients. The introduction of HER2-DX will help us to identify other subgroups that, even not achieving what we define as the perfect response, that is a PCR, they benefited as well because their prognosis was extremely good at 3 years. And that's one very interesting thing, is that we can increase the number of patients in the future that will not require chemotherapy or other aggressive treatments. We cannot compare, we can complement. Okay? So PCR is an extraordinary tool, prognostic factor. So patients who achieve PCR, whatever the treatment, they have a very good behavior. But it's true that HER2-DX can also identify patients that, although they do not achieve a PCR, they will do also extremely well. So we are able to differentiate the chances to respond to the overall benefits and the behavior in terms of risk, high risk versus low risk. That's the great thing about PHERGain. We are just starting to explore sub-studies, looking for biologics that could help us to identify and characterize better the patients. HER2-DX is one example, but we present here also data from another biomarker, that is TROP2. TROP2 is a biomarker that is well known in HER2 negative because it's a marker for sensitivity to anti-TROP2 agents. But what we have shown here is that tumors that expresses TROP2 as well as HER2, they have mechanisms of resistance to HER2. So TROP2 appears as a mechanism of resistance, so patients harboring TROP2 have less chances to achieve a PCR. And as well, when we looked in the samples from patients that do not achieve a PCR, we observed that TROP2 has increased expression in the vast majority of those patients. So indicating that this is a truly mechanism of resistance. So in the future, we could also start to design studies targeting TROP2 to be complementary or to having the opportunity to overcome those resistances. But again, it's just the first studies. We are planning a lot of more of other studies that will also complement the clinical data that we have.